Well, good evening. I'd like to thank all of you who are joining us this evening for the Society of Cardiovascular Anesthesiologists and Society of Thoracic Surgeons educational webinar this evening on the Adult Cardiac Surgery Database. I am chair of the SCA Quality and Safety Leadership Committee, and I'd like to thank the STS and our chairman of the STS Database Committee, Dr. Miklos Kurtai, for arranging this webinar. We plan to record this webinar and we will have this on the SCA website and the SCA app. As chairman of the SCA QSL committee, I think it's very important that our SCA members and myself have a good understanding of what's in the adult cardiac surgery database and how we can work with our cardiac surgery colleagues in our local institutional quality programs to assess and improve our patient care and outcomes. So I'd like to thank you all for taking time to be here tonight. Our guests this evening is Carol Crone, the STS data manager at the STS. She's an expert on the adult cardiac surgery database. We have Melanie Bent, who's from the IQVIA company, which houses the STS database. Dr. Miklos Kurtai, chair of the SCA STS database committee, and Jim Pavletic, who is the Veritas representative. Veritas is a new SCA management company. They've been very helpful to us through this transition. Briefly, I'd like to have Jim give a few words and to our SCA members. Jim?
Sure. Thank you, Bruce. I'm glad everybody has taken the time this evening to join us. I think you're in for an interesting and educational webinar. We're happy and proud to be working with SCA and to support the activities of the SCA and the STS as it relates to working with the database. They tie in very nicely to the QSL and to the quality improvement activities that the SCA is working on. And I know that tonight's content will be addressing that throughout the presentation. And look forward to hearing it myself.
Thank you very much, Jim. So with that, I'd like to thank you all for attending. The way this is going to work, I'm going to let Carol Crone and Miklos Kurtai sort of moderate this webinar. So now I'd like to turn things over to Dr. Miklos Kurtai. Thank you, Miklos.
Dr. Boland, Bruce, thank you very much for the excellent introduction. And I also like to thank for the opportunity to bring this webinar together today. And particularly, I'm glad and grateful for our panelists to be able to help us out to put this webinar together and make it a successful endeavor of our activities and missions that is important for us in terms of collaborating with the Society of Thoracic Surgeons on the adult cardiac surgery database. So the way we would like to conduct tonight's webinar is basically as soon as we jump into the main sections of this presentation, we would like to encourage the participants to use the Q&A function to raise any potential questions they would like us to respond to at the end of the presentation. So quickly, I was hoping to just going over the history of the adult cardiac surgery database and the participation and the collaboration of the Society of Cardiovascular Anesthesiologists in the database. So as you can see in this timeline, the database, the adult cardiac surgery database, was created back in 1989. In 2013, a partnership was formed between the STS and the SCA, and the so-called anesthesia section of the adult cardiac surgery database was created. Back then, there was no direct link and merge between the surgery and anesthesia section of the database, but by 2017, the anesthesia module was actually merged into the adult cardiac surgery database. And subsequently in 2020, we underwent a major upgrade of the adult cardiac surgery database as well as the anesthesia section, which is included in the adult cardiac surgery database section. And also this was the year when we transitioned, the Society of Thoracic Surgeons transitioned from the U Clinical Research Institute and started working with IQVIA, which will be covered in the second part of the webinar, in terms of creating an interacting online feature by which participating members and sites can actually look into real-time data and have a better understanding visually in terms of how they contribute to the database and what the distribution of the cases they contribute with and how those potentially could impact the quality of outcome and outcomes of the cardiac surgery. And with that in mind, I'd like to hand over the word to Carol Crone, who is the STS Senior National Database Manager. And we are really fortunate and glad to have Carol on the webinar and give us a quick tour of the adult cardiac surgery database as it pertains to the surgery as well as the anesthesia sections of the database. Carol?
Sure. Thank you, Dr. Kurtai, for the generous introduction, and thank you, Dr. Bolin, for asking me to present on behalf of the STS for the anesthesia section of the database. Let's see if I can get my slides here. So the STS database, as Dr. Kurtai stated, started in 1989, and currently we have more than 7 million records. We have over 1,000 national and international sites participating. It is voluntary. There is no mandate for sites to participate, and we have about a 90 to 95% saturation rate from national sites. We have 70 sites participating in the anesthesia section with over 2,900 surgeons and over 770 anesthesiologists. We produce quarterly benchmarked reports, which we will get into in just a little bit. With the IQVIA transition, we now are presenting those in a dashboard format, and we are the basis for standardizing data collection across adult cardiac surgery patients. So I'm going to bring over my, here. We're going to walk through the data collection form briefly and kind of touch more on the anesthesia section than we have in the previous webinar, which I'll show you where that's posted at shortly. Here we have the STS Society of Thoracic Surgeons website, and we have our different sections here. In the registry section, we'll find the different databases we house. The adult cardiac surgery database is where the SCA section lives, and currently we're on version 4.20. I'm going kind of fast and happy to, all of this is in the previous webinar that is posted on the SCA website, and I'm happy to review anything if I go too fast. Happy to revisit that after the presentation when we get to the Q&A section. So this is the STS National Database Form for Adult Cardiac. This version went live on July 1st, 2020, and it will be live until, I believe, the end of 2022. We'll go live with a new version, hopefully January 1st of 2023. Our versions live for about 3 years, and I'll briefly run through this. We do have, I believe, 7 different risk models. So you'll see the risk variables are notated with the double asterisks. And then we do have NQF approved measures, which are things like the CABG composite measure, the mitral valve composite measure, things like that, that have various endpoints like prolonged ventilation or renal failure following coronary or cardiac surgery. So I'll just briefly run through this, and we're going to spend a little bit more time in the anesthesia section to introduce you to that. We collect the basic demographic information, patient age, sex, things that we use for national identifiers. This assists us with doing linkage to the NDI, which is a project, the National Death Index, which we are currently working on now and hope to have that complete within the next few months to see longitudinal outcome. We collect things for geocoding, like the permanent street address. And although these are PHI, we do research. We do research with these through our research center that is looking at geocoding and socioeconomic factors associated with either increased rates of cardiovascular disease or patients' outcomes. We get into the hospitalization. We ask basic hospitalization information, and then we get into the insurance section, which covers, we really are looking at Medicare, and if we have dual eligible patients, we see a higher increased risk with those patients compared to other insurance carriers. And our major section that we focus on, collect basic information about the admission date, where the patient came from. And we get into the risk factor section, and this is where you'll see a lot of double asterisks going on. And these are all things that are somehow related to an increased risk or have some type of, maybe they're a covariate that is used in risk modeling that may be impact higher if they're combined. If you have diabetes and hypertension, then it would be a higher risk than if you had either of those separately. Endocarditis, and then our tobacco use. Chronic lung disease, we are looking at those definitions a little bit further and how that how the diagnosis for chronic lung disease has evolved in the past few years. So we are actively redoing that. And then other things related to pneumonia, drug use, alcohol use, your liver disease patients, cancer. And then we get into this cerebral vascular disease section, and we're looking at patients who have had prior CVAs, when those CVAs were, and the stenosis of any arteries, and if those patients have had prior carotid stenting or surgery. We collect your basic labs. Now we collect labs here, but you'll also see when we get down to the anesthesia section that we may get more specific in labs, or we may start collecting different labs, and that's really the work of the SCA workforce that has been placed on this to review and kind of pick out things that are more important to the anesthesia section and anesthesia care of that patient. So you'll see that as we get further down. We also started collecting COVID-19 data on cases back in April. And to date, we ended our first harvest close. And when we looked at the initial set of data, our COVID positivity rate was about 0.7% for any yes. So either prior to hospitalization, in hospital prior to surgery, in hospital after surgery, or within 30 days following surgery. And that rate was about 0.7%. So these are all things that are interesting to study, and actually quite relevant to what sites are undergoing right now with the care of patients in this current pandemic. We then collect information on previous cardiac interventions, and we get down to any previous cardiac interventions, previous valves. We get granular in that section, and then previous PCIs and when those PCIs were performed. And if that PCI failure was resulted in this current procedure, emergent or urgent procedure. And then other cardiac interventions, including ablations or procedures on the aorta, electrophysiology type procedures, and transplants, and NVADs that sometimes go along with those transplants. And then we get into the preoperative cardiac status of the patient. And I hope I hope I'm not going too fast for folks, but I wanted to get down to the anesthesia section. Preoperative cardiac status, we talk about prior MIs and when, and we look at that time frame. There's of course an increased risk if that patient has had a recent MI and the timing of that MI. We also collect New York Heart Association classification, and this previously was a child of heart failure. We removed that out so we can capture this on the functional class, specifically for those mitral valve patients. We're looking at cardiogenic shock and resuscitation as all having an increased risk for patients as well. And most of these are pretty intuitive, but the risk models are actually quite extensive when they're built, and it takes a lot of statistical analysis to build them correctly and make sure that the things that are chosen have a statistical significance in the increased risk. So it's not the surgeons just picking and choosing what is going into the risk model, but there's actually a method that is highly statistical in building those risk models that looks at the impact of each of these factors. We collect AFib and any other types of arrhythmia. AFib primarily, we're looking at these patients and if they, specifically we have beta blockers preoperatively, and if that patient received the beta blocker preoperatively, that's one of our NQF measures. And then we're also looking at patients for reporting purposes at the site level related to AFib and helping sites manage their AFib occurrences after surgery as postoperative complications by excluding patients who are in AFib at the time of surgery. We collect medications. These are preoperative medications, and we're looking at making sure that patient hopefully was not on, I believe I'm saying that right, the ACE or ARB within 48 hours, and then that they did get their beta blockers and all of their other anti-anginal medications we are collecting. We're looking at antiplatelets and the timing specifically for ADP inhibitors and aspirin when those were discontinued prior to surgery. And then anticoagulants and thrombolytics, and then the inotropic IV inotropes and the lipid lowering and steroid medications. Prior to surgery, we're also looking at the hemodynamic section, which is looking at your results from the catheterization, or if the patient had a CT angio or anything else that would help identify coronary artery disease. We are just collecting information. We were getting really granular and collecting information specific to which part of the LAD, in which part of the circ, which part of the RCA distribution in previous versions. We've now condensed that down, just looking at the system as a whole, and if there's any LAD distribution stenosis greater than 50%, and if so, was it 50 to 69 or 70%? This new greater than or equal to 70% came out of guidelines that consensus guidelines, multi-society guidelines that state that coronary artery disease is considered to be greater or equal to 70%. So we know that our surgeons do surgery on diseased vessels with less than 70%. So we're collecting both to kind of evaluate this definition that recently came out from those multi-societal guidelines. And then we get into ejection fraction and PA pressures. We get more specific when we get down into the valves by collecting the hemodynamic, the pressures of the valves and the velocities. And then the disease etiology for aortic valves. When we get into the mitral section, we kind of collect the same information. However, we went back and we collect on the Carpentier classification. And if that's documented, we can capture that here. If the diagnosis is not specific to Carpentier classification, but it's more of a generalized, I guess, if you will, diagnosis, we can link that back to the Carpentier classification so we can capture both and do analysis on both of those. And then we, of course, the tricuspid and the pulmonic valve, same types of setups with the regurgitation, stenosis, and then the echo measurements if they're available, and the disease etiology. And then we get into the operative section. This is, we worked closely with our couple groups from pulmonology. We worked with the society and with a couple at the society, and I think the board or somebody who helped us along with the SCA review this section and look at what we're collecting here along with our perfusionists. We capture the status. Emergent salvage removes a lot of the patients from a couple of the, or remove the patient from the couple of the measures that we report out. And then we have the reasons here. Some of the new reasons that we added in with this version are related to failed transcatheter valve therapies, specifically acute annular disruption and device malposition were added in. We get then into the approach and was a robot used, and if it was used, what part of the procedure was it used? And these questions here about the procedure types will open up following sections that get more granular into each of these types. So you'll see a section on coronary artery bypass, on the aorta, and then on the 4 valves. We also collect data, more granular data on mechanical assist device and ventricular assist device. The mechanical assist device, we're intending to collect data on short-term assist device. The ventricular assist device also is intended for short-term use, where we see those. However, we do have sites that collect both in the STS registry, adult cardiac, and in the STS Intermax if they want to dual capture their long-term devices. Some sites do that. And that's just so that they have a complete set of data for all of their cardiac surgery patients through the STS adult cardiac. And then we collect AFib procedures and then other cardiac congenital procedures. Usually these would be specific to previous congenital patients. However, we also do have a congenital database, and some sites do dual capture within the congenital database and within the adult cardiac database. Right now, the congenital database is undergoing a upgrade that will go live in 2022, and we are going to include an adult with congenital heart disease section in the congenital database. So we'll be able to capture more data on those patients. And then we get into things, antibiotic selection, your temperatures, and you'll see more of this better data capture or more variables within the anesthesia section when we get down there. Your labs, your hemoglobin, hematocrit, glucose, perfusion strategy, and your circ arrest section. And if circ arrest, we added now the total circ arrest time and cooling time prior to circ arrest, and we added these primarily to look related to a higher incidence of strokes with certain timings. So we're looking at those a little bit more closely now. Hopefully I'm not saying anything wrong, Miklos. If I am, you can stop me and correct me.
No, it's absolutely fine, Carol. Thank you.
Okay. And then we get into just your basic intra-op management of that patient, including blood usage, any types of clotting factors that were administered, or antifibrinolytic medications, and then post-procedure, was a TEE performed before that patient left the OR, and what did that TEE show specifically for valve cases. We have a section on the bypass, on coronary bypass, and it's just asking your anastomoses, where those anastomoses went, what type of graft material was used. And then we get into the valve surgery section, which we first collect, if a valve was explanted, and then we collect information on aorta, mitral, tricuspid, and pulmonic. Similar questions for each section. The aorta section is slimmed down because we are now capturing roots or bentals within the aorta section. So you'll see those down there as we get there. And then the valves are implanted. Similar thing for the mitral section. We did clean this up and clean this up a little bit and got very specific on information that we wanted regarding just the neocord management, chordal transfers, or leaflet extension replacements. And then we get in the same type of information for tricuspid and pulmonic. The mechanical assist devices, we're collecting things like balloon pumps, ECMOs, and then we get into the VADs. And just very basic information, a lot less than what Intermax captures, but this is just for us to have a basic understanding of VADs that are implanted in patients in conjunction with a cardiac surgery, another cardiac surgery. We have other cardiac procedures. These are usually captured in addition to an analyzed procedure. These procedures alone are not usually analyzed. They would go into the other category and not be risk adjusted. And then we have our AFib section. We have the left atrial appendage obliteration, amputation, if they did a maze procedure where those lesions were made. And then our aorta section is rather extensive. We get into a specific history of aorta patients related to familial history, and then we get into previous procedures and any types of endo leaks. And then we collect more granular data on aneurysms and dissections. Right now, we have enough data that the Aorta Task Force is working with our Quality Metrics Task Force and initiating the build of a risk model for aorta cases, and they are looking at that data now. And I anticipated that will probably be about a year before we see something finalized, but it is exciting to be able to risk adjust these patients, and hopefully it'll be done sooner than later, and we'll have something good for patients and physicians, providers to make decisions related to their aortic patients. This is all pretty much pre-procedural information talking about specific to dissections or aneurysms. And then we get into additional anatomical and then measurements. And then specific to the intervention, we capture the aortic valve or root procedures here that are done in conjunction, either the root or it's done, with the ascending, or maybe an arch is done as well. We're collecting those here, and then we get into the root and then the ascending arch section and surgical descending thoracic or thoracoabdominal procedures. We have a separate section for the endovascular procedures, which is right here. Just very basic information about landing zones and arch vessel management, visceral vessel management, and then any other type of endovascular procedural information that's available. And then we have, this is additional procedural information about spinal drain placement, intra-op EEGs or IVUS, things like that are captured here. And then our device section for the aorta, which isn't very exciting. We capture the congenital defect repair, and we use the same list of diagnoses and procedures that's found in our congenital database, which is really quite a long list. And then we capture things like carotid endarterectomies or other vascular or thoracic procedures. In the postoperative section, this is the postoperative stay from OR discharge to usually through hospital discharge, and we collect things related. We actually added in this postoperative peak postoperative creatinine level within 48 hours of OR exit time, because a recent study or a few recent studies came out that said if this postoperative creatinine level was elevated within that 48 hours, that the patient is likely to have a worse outcome. So we're going to look at that a little bit closer when we have enough data to do so, as compared to this just the peak postoperative creatinine level prior to discharge. We collect basic blood information and any postoperative blood usage. These are all reported out as well in the IQVIA platform, or will be reported on in the IQVIA platform when we have the benchmarked reports available. Extubation time, ICU time, your post-op echo time, and then we get into postoperative complications, deep sternal wound infections or superficial, return to OR for any type of event. And these are all broken down further. And then any type of your normal postoperative complication would be collected here related to cardiac surgery. We get down into and we try to break it out so you don't have to answer all these questions if they're not applicable to your patient population or the patient that you're collecting this on. And then the discharge section is we follow patients for 30 days currently, and we do have a patient reported outcomes task force who is looking at doing PROs right now, and that's something that's in the pipeline and may come in the next few years where we're looking at more longitudinal. But with our NDI linkage, we will be able to provide at least at least some minimal data regarding patients and more than following 30 days. On discharge location, one thing that has changed in this version is that patients who are discharged to hospice are counted as mortalities. The percentage is very low for these patients, and most of them are considered operative mortalities even within the time frame that was allotted in version 2.9, but surgeon leadership at STS decided that any patient discharged to hospice would be a mortality, regardless of the time frame. Current operative mortality is considered 30 days from OR date. For hospice patients, we would go until when that patient expired. And then we get into the readmission and reason for readmission. Now below this form, we have the anesthesia section, which is this is the optional form that sites voluntarily participate in, to which we have 70 of our just over 1,000 sites, and we would be really great if we could get more sites to participate in this, so we have some good data. I'm sure Miklos will talk about this in a second, but we did have, or the SCA just recently put out the first paper related to the data that is collected within this section, and they are working on a few more that Miklos can talk more about, but that was triple published, I think, Miklos, so that was exciting. So this is the anesthesia section for sites who are participating in this. It's typically either filled out by your data manager or your anesthesiologist will fill this out. We capture the care team model and your ratio if you're doing an attending anesthesiologist to a CRNA or an AA. We capture pain scores at baseline, post-operative, and prior to discharge. And then we do your induction blood pressure, induction heart rate, and if a pulmonary catheter was used or not. We are looking for algorithms used to guide transfusion if your site has an algorithm that is used to do that. And then we worked on this section, this anticoagulation prior to CPB. We worked on this section quite extensively to kind of modify it and really get down to what is necessary for you all to have good data to make your decisions. So we have heparin prior to CPB, and if there was heparin, how much was given and what type of management was used. Did you use an ACT or a HepCon? And then did that patient who required heparin prior to CPB, did they end up getting FFPs prior to CPB and or antithrombin 3? So it's any type of event that was related to that heparin dose. And then we're also looking at bivalirudin or Ivatroban if those medications were used. And the viscoelastic testing and a volatile agent was used, and if it was used, which was used and when was it used. This is the select all that apply. So you could select any agent that was used and any timing if you used it multiple times. We get into the sedation medications, sufanitinol, Versed, fentanyl, and Remi. If these were used, what doses were used. Your multimodal analgesics, this is from OR entry to 24 hours post-OR exit, and how was that patient's pain managed? We are capturing ketamine, the local regional anesthesia, a lidocaine infusion, not the bolus, but an infusion, Tylenol, either IV or PO, the COX-2 inhibitor or nonsteroidal anti-inflammatory, these were BPO medications, and then dexamethasone IV, if any of these medications were used from OR entry to 24-hour post-OR exit. And this is, again, looking at pain management options for the patient. A core temperature source in the OR, and how did you manage, or what source did you use to measure their temperature, and what was the max temperature during rewarming? Again, I think this is related to increased stroke rate. Miklos, is that correct for the core temp max during rewarming?
Not only necessarily the stroke rate, but it's actually associated with a high risk of postoperative neurological complications, including postoperative cognitive dysfunction as well as delirium.
Great, thank you. And then we look at crystalloid given by anesthesia and the total amount given and what type was given. 5% albumin, 25% albumin by anesthesia, ANH, and what that volume was. The intra-op inhaled vasodilators, intra-op IV vasodilators, and then we look at the glucose tro and what that measurement was. If that patient received insulin and what the dose was in units. We look at the EEG, the intraoperative processed EEG or BIS, and then the intraoperative post-induction pre-incision TEE. And if that was performed, then the following questions. This is different than what is captured in the operative section of the data collection form, in that we look at the post CPB TEE in that section. And prior to that, we look at pre-induction measurements. We usually do not allow sites to capture post-induction measurements in the preoperative information, unless that's the only test that's available or it changed the procedural plan of care. So this is the post-induction pre-incision TEE information. And a few things I think that we added in there: the left atrial superior inferior size and the left atrial medial lateral size. And we captured the EF, the right ventricular function, mitral regurgitation, if there's a PFO, if the ascending aorta was assessed, and what the maximum diameter was, if there is erythromal thickness or mobility. We're looking at that as well. And some interesting data on that. The aortic arch visualized, if they did visualize it, the thickness and mobility. During bypass, we're looking at ABG management, arterial outflow temperature measured, and the highest arterial outflow temperature measured. Retrograde autologous priming of the CPB unit, and then total crystalloid by the perfusion team, and then albumin 5% by the infusion team, 25% by the perfusion team, and what was given. Hemofiltration volume removed by perfusion. They took off of the patient, volume off of the patient, and then inotropes and vasopressors used to wean from CPB. Now this is a pretty detailed section, a lot of great data, and it's really interesting to collect that within your site. The cell saver volume, and then protamine dose, and then this is the post-procedure use of the intra-op TEE. This is in addition to what is collected in the operative section, so we didn't want to duplicate efforts of the data manager. We wanted to get a little bit more granular within the anesthesia section, and we're looking at SAM, mitral valve, and then return to CPB for echo-related diagnosis. Was that patient off of CPB? You did the TEE, and then we had to go back on bypass for any of these reasons listed here. And then if it was related to ventricular failure, which ventricular, and if or biventricular. And then post procedure EF and what that was, and then the RV function. And then assuming your patient made it, we go into the ICU and we capture this information related to temperatures, your labs, your post-op INR, your white blood cell count. And these are from admission to post-operative care location. And I believe it's within a few hours we have that time frame set. This is to look at the management that patient received by you in the operation, during the operation, the anesthesia care of the patient, and to help with that, help look at that. We capture platelets, hemoglobin, your H&H, your fibrinogen, lactate, and then the peak glucose within 18 to 24 hours after OR exit time. We also are looking at propofol or other sedation and post-op delirium. And then we get into the pain scores, which is the final two fields here. We have your post-op day 3 and your pain score at discharge. So this goes right back to the post-op pain management questions above. So this is the data collection form, and it is found on the STS website. In addition, within the website, we have the training manual, which gives a definition of what is being collected and then an intent clarification. This one that's pulled up here is the intra-op glucose tro, and it's this is just if a tro was performed from OR entry to OR exit. So we try to provide a time frame, and then the intent of the field and how we're collecting its milligrams per deciliter for this one. And then the intraoperative glucose control value, we want the patient's lowest value after induction of anesthesia and prior to OR exit. Miklos, did you have anything to add into this section here related to our training manual? You all worked very hard in providing these definitions and intent clarifications for the data managers to make sure that we're consistent in our data collection.
So excellent presentation, Carol. Thank you very much for taking us over and through basically the surgery as well as the anesthesiology sections of the database. And obviously what I'd like to point out here is that this is an ongoing process in terms of refining and helping to improve the definition of these data elements within the data collection form. And as such, we would also encourage participating sites and members to raise any potential questions. Those can actually submit it on the STS website, and Carol can actually give more information about that, which then will be basically sent to us, and we are happy to actually follow up with the a person who actually submitted the question and respond to those questions accordingly.
That's great. Thank you, Miklos. Yes, we have on our website, we do have a link for data managers to submit in their clinical questions, which we do clarify with the site. So I'm going to stop my presentation there so we give Melanie enough time. I am going to hand it over to Melanie Bent, who is our business analyst from IQVIA, and she's been with us since the beginning of our transition from DCRI to IQVIA for our data warehousing. So Melanie?
Thank you, Carol, and thank you to the SCA and STS for inviting me. Let's go ahead and give a brief overview of just the functionality. The application is a platform that's available 24/7. So data managers, surgeons, anesthesiologists, anytime that you have and you want to be able to log in, it's a web-based, cloud-based platform, and you would get in and be able to see information that has been loaded within your site real time. What I'll show later on this evening is going to be an interactive dashboard. And with the information that is loaded by the data managers, you're able to then review that interactive dashboard within minutes to be able to see the information then come to life on the dashboard. There are many other reports that are available to the data managers where they're able to review at the time of when they're loading that data, interactive validations to let them know if there are certain ranges per se, let's just say for labs that are set within the data specifications. It'll let them know that if it's meeting the specification expectation, the information that's being passed into the database, and it will basically prevent bad data from coming in based on those validations, or of course, give them a warning or an error to allow them to know that they need to review that information that's being loaded. So with that, let's go ahead and I'll share my screen, and then we can just take you through what the data managers would see or you would see when you access the system. So I'm going to share my screen, and if Carol, you can give me a thumbs up or just so you could let me know that you could see my screen. Yep. All right. Thank you, Dr. Kurtai. All right. So when the user logs in, I'm already navigated to the primary operational reports menu. And here you'll see that they have a couple of reports that they're able to review. And so what we'll focus on this evening is going to be the ACSD, the Adult Cardiac Participant Dashboard. And you'll see that there's other tools that will allow users to be able to see if there are missing variables, for example. So data is now loaded into the system and they wanted to do a review to see what information is potentially missing, they have access to review the missing variable report. Another report that's available is called the Harvest Summary Report. And this gives them an overview of any outstanding errors or warnings that are existing on any record that's in the database at the moment. So they're able to review that and by entering in a surgery date range and see what are outstanding errors or warnings that need to be addressed so they can have that holistic view. I'm going to come to the dashboard in a moment so we can take a deep dive at that. And then there is another report which is fairly new to the community, where we now have the Harvest One data that has been analyzed by DCRI. We have that available within the dashboard. So they're able to actually now review their risk adjusted information that's related to Harvest One. So those are the current reports that are available, but there is definitely more that is coming. We have been doing this project in an iterative manner where as we get different components ready, we then release it out to production, those enhancements and things that are coming, such as what Carol had also stated earlier in regards to benchmark reports. So those are reports that will be coming also. So I've already loaded up the dashboard just because I know that we're on a time frame and I just wanted to set up kind of just the parameters and get us into the report quickly. So the first thing, when the user goes in, they will have the ability to select a predefined reporting period or enter in a specific date range. So I've already entered in a specific time frame, and the next set of parameters that they would select is the procedures. I went ahead and selected all, but as you can see, we do have the procedures broken out, and they are able to go in and do a combination if they would like. If they wanted to see isolated cabbage and possibly just maybe a mitral, it just all depends on what they would like to review in that moment in time. They have that ability to do that. So you can see all of those options are available. They would select what they want, or if they want to review all, we have that option here. So with that, I've already generated the information that is available for all cases. And this is a test site that I'm using at the moment. So I don't have many cases that are available within this site, but once the report generates, you'll see that you'll have your total number of cases underneath your My Site column. So just wanted to let you know that, again, test site. So we have a small number of records that we're going to deal with. But coming over to the section to the left, you'll see that it gives you an option where you can select an actual report. So I think this is a great segue, especially since Carol walked us through the data collection form, and really the dashboard follows that same model. So you're able to be familiar with what is being entered on the data collection form, and you're able to come into the dashboard and you're able to review that same format, the same sections. So you'll see the first actual section is demographics. And here you'll see that we have some predefined graphs, and this is applicable for each of the sections that are listed here. You'll have predefined graphs that will highlight a specific variable. We have 3 that are listed for each report, and each of these graphs are interactive. And so if you wanted to just see results related to your female population, you'll notice that you have this label and then of course the bar graph that does a comparison of the My Site versus the STS. And here, if I wanted to just look at the results related to my female patients, I would just select that graph bar, and then you'll see how it will automatically update, and it's going to populate all of the patients that are listed as female per the data collection form. And so you're able to immediately use that as an interactive piece to the report. And you're also able to come to the middle section, this tabular section. And here is where you're able to view the information that's listed. And what I'll do is just maximize this, because you'll notice that you do have an option to scroll, But if you wanted to just basically focus on just this section, you are able to right click on the section and you're able to maximize that list. And you will then see that full list of variables that have been made available in the report and the different variable selections. So here, if I wanted to drill down to see the patients that fall into the population of 30 to 44-year-olds, you'll see that I have a count, which basically I have 9 patients that fall into that category. Once I select that, and because I'm in the full view mode at the moment, you're not able to see the drill down. But if you take a look, and maybe a little bit hard to see, you'll see that there's some navigational tools here where I can go previous, or I can go forward, or I can restore back to the main dashboard view. But if I selected this item here and I wanted to just stay in this mode of seeing just the drill down, I can hit next and you'll see it brings me to that list of patients. And many of the data managers, when they go in and review this information, what they want to do is be able to export that information to Excel or some type of table, and then they could go ahead and look at that population in that way. So you have that type of interaction where you're able to export this to Excel, you're able to print this to a PDF. So many of the features that are available here really comes with being able to navigate and pull that data and be able to review that in a different format. And that is something that the data managers have asked for and we've been able to provide. The other thing I wanted to point out is that we're able to, if I wanted to get the full results of all of these items that are on this tabular section, I actually could highlight that section, and as you can see, and I can pull this all the way down. If I just wanted to get all of the results related to showing that in the bottom portion of the report, I could do that also. So there's many different things that you're able to do within the report to be able to pull that data out. So I just wanted to show you that type of interaction. And you can see all of the graphs are now in a brighter color. So it's letting me know that everything is selected at this moment. So just going down, and I know that we are coming to time, so I just wanted to bring you to just different things that once you're in the report, you're able to drill down and see specific information. One thing that I wanted to highlight is within the risk factor section. So let me just bring that up, where even if I wanted to see if, for example, if there was a patient that had missing height information or missing weight information, we have that type of granular information to be able to drill down and show the user that actual case where the information is missing. And so if I wanted to go in and see who that patient was and be able to do that update for those users that are currently using the system to do direct data entry, they're able to go in and see this information and make that update in real time. So just wanted to at least point that out, that within the system, as soon as the information is saved and available within the database, you're able to go in and interact with these reports and get that feedback real time. So and I won't go through each of the sections because again, time is running out, but I wanted to also show you that the anesthesia section will appear if the site is has elected to participate with collecting anesthesia data. So you'll see that it's available here, but for those sites that are not participating, they actually would not see that. I'm in a test system, like I said before. I'll go ahead and show you that the section is available, but I don't have information that's populated specifically for anesthesia. But if I did, of course, this information would be populated with that information based on what was entered in on the data collection form. So with that said, it looks like we're at least 8:55. So I'm going to go ahead and stop here. And Carol just wanted to know if there was anything else that you would like me to show, but if not, I'll go ahead and turn it back over to you.
Oh, Melanie, go ahead, Dr. Kurtai.
Sorry, Carol. Melanie, a quick question. So obviously, this is really fascinating, and thank you very much for this great overview and a presentation of yours. So let's say members obviously would be interested in learning more about the IQVIA dashboard and what it can do for them. So how, or is there a way they could actually follow up with STS or IQVIA if they would want to have actually learn more about how the different embedded features within the dashboard could be used?
Absolutely. Carol, do you want me to defer to you? Usually the communication would start with STS, and then from there we coordinate with providing any information that's requested by STS. So I would just recommend the first point of contact would be with STS.
Yeah. Feel free to reach out to me for more information on the IQVIA platform. We do host twice monthly webinars for the adult cardiac sites. One of those is a user group call where we're answering questions and things like that for the data managers. The other is an educational type of webinar where we are providing updates on the IQVIA platform, showing folks how to use it and how to get the most out of the platform that's available, because it really is quite fascinating, everything that's able to be done within the IQVIA platform for the database. The benchmarked reports, which are the reports that will show the like groups and the STS groups against your site's numbers, will be available in the next coming weeks. And that will be very useful. One thing that I'd like to point out is that previously the anesthesia participants only received a PDF of the anesthesia data. So this is something new for the anesthesia participants to be able to look at all of the patient's data from the preoperative section all the way through the postoperative complication section, along with the anesthesia information. And so that's something that's new as well. And I'm happy to take any questions on the anesthesia section if you have them after this webinar. Thank you, Melanie. That was a really great presentation. And the more I watch the IQVIA platforms, the more I learn and the more I'm fascinated by all of the functionality that's held within it. So thank you.
Welcome.
Thank you, Melanie. We've got time for two quick questions that were actually posted through the Q&A section of the Zoom call. I'm happy to take the first question. This is from Anubhav, and the question is, what is the best way to document ANH volume? Is this a visual estimate? Are hospital sites using any quantitative way to measure this weighing scale? And obviously, this is a question or as well as a variable that could be approached from two different angles. If there are hospitals that use weighing scales, that's going to be the more adequate way to tell how much volume of ANH was drained during the cardiac surgical procedure. But we also appreciate the fact that not all hospitals actually use such technique to quantitatively define how much volume of blood was drained from the patient. As such, we are happy to take information considering the volume that a transfusion bag can hold, which is 350 mils. And if that information is reported back to the STS database, that is also acceptable. This is, by the way, a frequently recurring Q&A type of questions we tend to receive. And certainly this helps us to improve the data explanation and collection process, especially when the next time the database is up for an upgrade. Carol, would you like to take the next question?
Sure, thank you. The next question is from Diane, and she states, are any centers extracting STS anesthesia data from Epic and importing it into their STS registry software? And this is a great question, Diane. We actually get this not just on the anesthesia section, but for the rest of the database related to EHR integration into the vendor software. At this time, STS only allows a limited number of fields to be automatically abstracted, and those include things within the demographic section, and then the unique device identifier, the UDI section, fields to be automatically abstracted at this time. We are working with our informatics task force to see if we can automate more data abstraction. It also comes down to the definitions and what's going on within the EHR worlds related to mapping and things like that, as it can get rather tedious, and we just have to ensure that the integrity of the data is maintained, and we do that right now without automated abstraction. So we're trying to balance the integrity of the data with lessening the burden at sites for data abstraction. That's a great question. Thank you. Dr. Kurtai, there is just a couple things. I know we're at time, but I just wanted to show folks on this webinar, if people wanted to stay on. This is one of the tools that is available on the STS website. This is our resource utilization tool. It's found under resources, and then the resource utilization tool. You would just have to accept the terms for it, and then it'll bring you here. And you can select, this is all of the STS data, so not site specific, but you can select your procedures here, the status of procedures, different demographics related to the patient, different disease processes, and you would be able to see those patients and the STS averages for total mean vent hours or things like that. Down here on the bottom, you would have outcomes broken out further if you were interested in that. So ICU readmission, this is for a CABG patient for, let's see, if we looked at just elective surgeries and we wanted to look at just male patients, we could see that that would be 2.2 or almost 2.3%. And this is really great for site resource utilization, and something that would probably be very, very helpful at some sites when they're trying to determine how their resources are placed. So I wanted to share that. And then the other thing I would like to share is the practice resources. This is the SCA website, and this is where you'll find our previous recording. You'll find here more information about the database. This is practice resources, clinical practice guidelines, the e-manual of cardiac anesthesia. If you click on the STS database here, you'll find the link to the recording to our previous webinar from August 19th. And it'll also link you back to our database if you are interested in participating in the anesthesia section. We would love to have you, and I'm happy to help with any questions you have. If you're interested in getting started, I can assist you with those and work with Miklos to work any clinical questions out that you may have as well.
Absolutely. This is great, Carol. Thank you very much. And as you can see, some of the contact information is also displayed in this slide. As well as, Carol, we have a last minute question. So I think this is probably more a question for you. So would you be able to address that, please?
Sure, absolutely. So this question is related to, this is coming from Roman, and it's related to a list of approved vendors for both the surgical and anesthesia modules. So when our vendors do get certified, they are certified both on the data spec build, the software specifications, and then they are, the second certification is on the risk model building. To make sure they're calculating risk scores appropriately. They are in that certification, they are additionally certified within the anesthesia section. So this is the STS website, and then under registries, the STS national database. If you're interested in finding out what vendors are approved, you would go, it's located underneath become a participant. And it's kind of buried, but I'm happy to show that to you. This is our list of certified vendors. Under each vendor, you'll see we have the date that the version went live. Under each vendor, you'll see what they're certified for. and you'll see their contact information if you're interested in getting more information from them. For adult cardiac surgery, ARMIS, for example, ARMIS is certified on the current version, and they are fully certified in both the data spec, software spec, and in the risk model build. And they're also internationally certified. So if you have a site that is not within the United States, but if it's in Europe or overseas, they are also certified to be their vendor as well. So hopefully that helps.
Thank you, Carol. And then I guess this is a kind of link and information we could also post on our SCA website. So Roman and other interested SCA members could actually use as a resource if they want to learn more about the different vendors that are actually licensed to work with STS and STS data.
Yes, of course, sure.
Perfect. With that in mind, I really like to thank everybody, our panelists, as well as our participants to participate in this excellent webinar. As we also detailed already, this webinar has been recorded and will be posted on the SCA website. And feel free to continue to submit your questions. We are happy to reach out to all interested parties and address those questions. And continue to work with our members as well as participating sites to make it a successful mission and endeavor and a collaboration between the two societies. Thank you for your attention.
Thank you, Miklos. Thank you, everybody, for joining. Have a great night.
Thank you. Have a great night.